Good evening, everybody.
Yeah, good evening, sir.
Uh, we will have to wait because our resident is just reaching. It will take 5 to 7 minutes, 5-10 minutes.
Okay, sir.
Hello, Bakshi sir.
इथेच आहे.
Sir, I can discuss targeted therapy in bladder cancer if you want.
शुअर जसं तू प्लॅन म्हणजे पुढे घ्यायचंय तसं देर इज नो प्रॉब्लेम.
Okay. मग मी स्क्रीन शेअर करू चालेल?
हो, तू स्क्रीन शेअर कर. अगदीच त्यांना एक केस पाहिजे होती, तर मी एक छोटीशी ब्लॅडर कॅन्सरची केस पाहिजे दाखवतो.
ओके चालेल, मग मी थांबतो
आणि मग तू कंटिन्यू. आणि
पहिलं कसं करायचं ते करूया, मग आम्ही चालू करतो. तुम्ही सांगा मला, ठीक आहे?
So Ganesh, we will just wait for 5-7 minutes and then we will start. Okay?
तो कोई है नहीं है मतलब.
No, 14-15 people will join in another 5-7 minutes. Hello?
Yes, sir. ये क्या स्क्रीन दिखता है क्या? स्क्रीन दिखता है ना कि नहीं? हेलो
सर, हाँ विजिबल है सर.
महेंद्र, एक केस है.
Okay. हाँ, we can see your slides.
विजय सर भी ज्वाइन हो गए.
Vijay sir, good evening. लग रहा चले गए कि
चले गए. चलेगा तो पता नहीं, मतलब ये केस का क्या होने वाला है. आई थिंक मैं ही पढ़ लेता हूँ ये केस, ज्यादा अच्छा रहेगा.
हाँ सर, बेटर है कि मेक अ सिनेरियो, क्योंकि हम लोग फिर we will go into the revision of
कुछ
case
पॉइंट आया
approach.
वही पूछते, वरना इट इज ओके.
हाँ.
ठीक है. तो अभी विजय इज ऑलरेडी ज्वाइन, वो भी कुछ दिखाने वाला है.
तो एक बार पूछ लेते हैं गौरंग शाह सर से, कैन स्टार्ट और when he gives green signal.
वो गए सिग्नल लाने के लिए.
गौरंग शाह सर होंगे.
मैं भी म्यूट कर लेता हूँ.
Who is answering today?
चालू करने का क्या?
नहीं, just wait ना 2-3 minutes. हमारा जो residents लोग भी सब just. Who is answering today? Prasad is answering?
Answering.
नहीं. So you will be only discussing, na, Ganesh? I think Mehraj is answering today.
Good evening, sir. Yes, sir.
Okay, Mehraj. Who else is there with you?
I'm not sure, sir.
Okay.
चलेगा? Okay. एक केस है.
हाँ, एक case. So we just Mehraj is there to answer.
तो अपन
She is,
चालू
I think.
करते हैं.
So we have got one student to answer. So we can just, you can just,
मैं
you
केस
know.
बात करता हूँ. आपको किसी को लगा तो पूछ लो, वरना इट इज ओके. मतलब
Okay.
मतलब किधर किधर ये एग्जैक्टली वो हिस्ट्री फॉर्मेट में नहीं है.
हाँ,
मैं
no problem.
पैनल डिस्कशंस में पूछता हूँ, वैसे है ये.
हाँ,
सो वेरेवर यू महेंद्र वगैरह फील ना सर, आप पूछ लो जो पूछना है.
हाँ, okay, okay.
एंड विजय, आर यू देयर? ही वाज
Sir,
देयर.
I'm there.
यस यस. तो आपण चालू करूया. चला.
Yeah, yeah.
तर चालू करने का क्या?
हाँ, ठीक. Just 8 normally 8:15 को हो जाता है. Just 2 or 3 minutes and we start.
क्या चल क्यों नहीं रहा
I
है?
just see who is वो अपना सब लोग ज्वाइन किया है कि नहीं किया है.
वैसे भी विजय इज रेडी टू टेक इट डायरेक्टली आल्सो. ऐसा कुछ नहीं.
बट आपका एक शॉर्ट केस रहेगा. आई थिंक ओके.
ठीक है सर.
So Shashwat is also there.
Yes,
Shashwat, you will be answering, correct?
Yes, sir. Good evening, sir. Yes, sir.
Good evening. Good. So Mehraj is there and Shashwat is there. So we can just have two of them. Now 1 minute and then we start. Okay, Ganesh?
Okay. Sir, moreover, I will be presenting.
Yes, sir.
बाकी विजय सर भी कुछ सवाल पूछेंगे और वो सिखाएंगे बाद में.
जी सर.
आज पंकज सर का बर्थडे है ना? पंकज
Yes.
सर पता नहीं.
हाँ, yes, है सर.
पंकज सर, हैप्पी बर्थडे.
पंकज, हैप्पी बर्थडे पंकज सर.
विश यू अ वेरी हैप्पी बर्थडे.
Thank you very much, bhai.
सर
Yes,
वीडियो कॉल कर
today-
लीजिए.
Today his Pankaj's birthday.
स्पेशल आइसक्रीम भेज दो सर सबको.
ठीक है
हाँ.
भाई. मुझे बोला या गौरंग शाह साहब को बोला?
सर आप दोनों भेज सकते हैं सबको. इतनी कैपेसिटी दोनों में है, हमको पता. मैंने गौरांग शाह सर को बोला था 2 महीने पहले कि ये फैकल्टी का एक छोटा सा डिनर करते एक बार,
Oh,
Yes.
that's a wonderful idea.
Correct, correct.
और गीते सर को हम लेके आएंगे प्लेन से, एक दिन शाम को 5 बजे बुलाते और अगले दिन सुबह भेज देते।
Yes.
सर आपने आवाज दिया कि मैं पहुंच जाऊंगा, चिंता मत करो।
अरे, I have a better idea. Let's all go to Aurangabad.
वेलकम,
ठीक है।
ऑलवेज वेलकम।
वो भी ठीक है।
No, but what Ganesh is saying that we must have now.
Yes,
Definitely. We'll just plan out.
अपने साथ जो फैकल्टी रही है ना सर, चाहिए तो उनको
सबको बुला लेंगे.
हाँ,
Even I feel that students who have answer will call them also. So at least we know who those 5-10 students who are regularly answering. I think Ganesh, you can start now.
चलो ठीक है। So this is mainly today's welcome everybody. Mainly today's discussion is about metastatic disease, and let's start with bladder. If time is less, then as sir said, we can continue the kidney and baki bladder. Upper tract follows bladder probably, and we have guest faculty Dr. Vijay Patil, professor in medical oncology with us. Dr. Mahendra Pal is also with us. So 58-year-old male underwent radical cystectomy with ileal conduit for a PT1G3 urothelial carcinoma, solid tumor on right lateral wall of bladder. So we start with that in 2015. This is the histopathology report. High-grade solid urothelial carcinoma invading up to perivesical fat. That is PT3A. Posterior wall, right lateral wall, and dome of bladder. Intravascular emboli and perineural invasion seen. However, all the margins are free of tumor. Now, my question to you is, if it says perivesical fat involved, how can we say margins are free?
Sir, other surrounding organs are free.
Organs are dur, na? What is your concept? Perivesical fat involved with cancer and all the margins are free means?
I'm not sure, sir.
Sorry, if Mehraj doesn't answer, then Mahendra Pal sir will throw light.
It means that closer to the bladder, the fat may be positive, but far away it might be negative.
Okay, that is right. So wherever there is a surgical cut, it is negative. Means beyond the bladder wall, perivesical fat has come positive, and further there is tissue which is negative probably. So that is the meaning. 1/8 lymph nodes positive on the right side, 0/6 on the left side. So another question, Mehraj, how many lymph nodes should be averagely present?
At least 35,
बहुत ज़्यादा हो गया.
25.
Sir,
Mahendra sir.
below 10 is a risk of pelvic failure, sir, and it is recommended above 16. Usually, nodes should be sampled, sir.
So there are publications with 9, 16. Mahendra sir, इस पे जरा आप बोलो ना, मतलब.
Yeah, so sir, there are many papers who recommend various range of the average lymph node present or node in the specimen. So as sir said, 9, 16, 20. So approximately 16 is the number, minimum 16 nodes should be present. Minimum. It can be more than that, but 16 to 18 nodes are the acceptable number of nodes to be removed with the specimen.
So here there are 14. That means sodicum.
Yeah. And one more thing, any high risk feature in the pathology report? Can you see?
Yes,
other
sir.
Than, other than margin?
Lymphovascular emboli are present, sir.
Yeah, LBI and PNI, these are the another two risk factor who predicts the micromets and the presence of lymph nodes at the T stage. Okay. Yeah.
Somebody is making noise. Can you stop that, please? Samsung M51, whoever you are, please shut the phone. Okay. So going ahead, so how do you plan treatment, Miraj?
This patient, since they have already undergone a radical cystectomy, now they can be given adjuvant chemotherapy.
Okay. So this patient was given adjuvant chemotherapy, 6 cycles of GemCis completed in March 16. October 15 to March 16. On routine post-op follow-up in December, sonography done, picked up right iliac node 1.5 centimeters, and a PET CT was done. PET CT shows multiple metabolically active, enlarged abdominal, retroperitoneal, and bilateral common iliac nodes demonstrating high activity, few tiny lung nodules, no appreciable activity, and no disease elsewhere. FNAC of the node, metastatic high-grade carcinoma. This is in December 16. March 17, after 3 months of alternative therapy taken by patient. Right lower leg edema, severe pain in right flank and lower abdomen. Sonography now shows right hydronephrosis, right hydroureter. Repeat PET CT shows recurrent nodal disease in pelvis and retroperitoneum with iliac nodal mass compressing right ureter, which is the reason for right hydronephrosis and hydroureter. Small subcapsular urinoma seen on the right side. Here. And these are nodes. What kind of nodal stations are these for bladder?
So these are M1A.
Yeah, so these are M1A disease. And these are the pelvic ones. So I think Dr. Vijay, I think you should actively join now and ask them questions, and then you continue teaching. So what are the treatment options? Shashwat, what do you feel?
Sir, he's a candidate for systemic therapy, and we have to must find out whether his eligibility for platinum drugs, because he's already received adjuvant therapy, and the PD-L1 status in the immunohistochemistry.
So Vijay, are you there? I mean,
Yes, sir, I'm there. I'm there.
I think at this point it's best to leave it to you.
Sir, so what
you
I
can
would
ask
do
them
is,
initial questions and go ahead.
so, sir, first of all, in such patients, I'll first look at what is the performance status of the patient and what is the expectation of the patient from the treatment. Now, whatever treatment we give, the situation is actually incurable. We can give modest improvements in progression-free survival and modest improvement in quality of life. So these discussions have to be done with the patient. Now here, if you see, the treatment was over in March. The initial recurrence happened in December, and now it is again March. So we have 1 year treatment-free interval with respect to the chemotherapy. So if the patient is fit, in such situation, I would actually rechannel the patient with gemcitabine and carboplatin. After 6 cycles, if the patient is still responding to the treatment, then we would consider giving him avelumab maintenance. That would be one way of treating the patient. If the patient on assessment is found to be like, and in this patient there is a issue which can happen because it's hydronephrosis on one side, that the patient's performance status is PS2, she has weight loss, or she has low creatinine clearance, and she's unfit for cisplatin. In such situation, then you can use immune checkpoint inhibitors like pembrolizumab, nivolumab in such situations. Now the next question is, should we check for PD-L1 positivity in such situation? The issue with PD-L1 positivity is this is commonly regarded as a biomarker, for giving immunotherapy. The thing is, PD-L1 is not a very perfect biomarker, and it is not the only biomarker which works. Now, there are good reports. We always see statistically people who have PD-L1 positive, they do better than people who don't have PD-L1 positivity. So we would come to know if the PD-L1 is positive at least more than 1%, then the probability of that you would respond actually increases. But the benefit is there seen even in patients who are PD-L1 negative when you talk about pembrolizumab, but the quantification of benefit is less. So what I'm trying to tell you is, if the patient is post-platinum as it in this situation and is not eligible for re-challenge of platinum, that pembrolizumab remains a choice which is irrespective of PD-L1 status, but the benefit, the magnitude of benefit would depend on the PD-L1 status. Higher the PD-L1, the patient would have higher benefit. If the patient cannot afford pembrolizumab or anything else in that situation, in such situation, you can also try giving other types of chemotherapies like paclitaxel or docetaxel, taxanes basically. Now there is also a role of testing molecular for this patient, and this molecular testing needs to be done especially for FGFR3 and for HER2/neu. And if the patient turns out to be FGFR3, we have the option of giving erdafitinib for this patients. The thing is, if it turns out to be FGFR2 or 3, and I'll show in my slides, then there is a relatively good benefit with FGFR3 with a response rate of around 30 to 40%, and it is durable of around 10 to 11 months in most of the patients. So first question, the answer should be, can we reintroduce the drug, same drugs or change? In this patient, it would be difficult because of hydrogeatonephrosis and all. But if there is reasonable interval, the reasonable interval is 6 months or more after the platinum, then you can re-challenge. Immune checkpoint inhibitors, if cisplatin unfit, then yes, we can use nivolumab and pembrolizumab. The license for atezolizumab is specifically for PD-L1 receptor positive patients only. Should we check for PD-L1 receptor positivity? Yes, it benefits in the terms of that the magnitude of benefit is more in patients who are PD-L1 positive. Should we do molecular subtyping? Yes, because if it is FGFR3 mutations are there and HER2 mutations there, and if the patient can afford, we have the drugs. So I would do molecular subtyping practically only in those patients who can afford these drugs. If they cannot afford, then the molecular subtyping is only of academic use. Any questions you have?
Shashwat, you want to ask any question? Any other information you want?
No, sir.
Any role of radiations?
Good question. That's a good question. Yes. In such situations when there are large bulky nodes, for palliative radiation can be given in such situations. But you must also understand that the benefit of radiation in such situations most of the time is limited, and it wanes off in 2 to 3 months in most of the patients. Any other question, Beta?
Ganesh, if you want to proceed further, or Vijay can start with his slides.
Yes, I think Vijay का better है. मैंने ऐसे ही चालू करने के लिए दिखा
नहीं तो नहीं you continue case ना.
Case continue कीजिए ना sir.
Case continue किया है मैंने sir, वो ऐसे मतलब. Just I'll show what was done. So the questions were, do we stand the right side? Because whatever residual function we want. Creatinine was 1.2, stoma functioning well, good performance status. And the question was, what would be the choice? So this particular patient was treated with nivolumab. And took initially 4 cycles, clinically pain disappeared in a week's time, leg edema also reduced. Follow-up PET was done, took another 4 cycles, another PET CT was done. So there is response seen. This is the response. You can see this is prior and this is post. Response is at many places. There are dates on the PETs. So June and August. So June and August. So you can see the responses how they have achieved. Sorry. Okay, at most places you are seeing response. So 8 cycles of nivolumab with this kind of response. Questions again remain. Let us hear presentation from Dr. Vijay later on. So generally questions remain that if sometimes you get such good responses, what to do, continue, how long, wait and watch, or whatever. The drug holiday was given in this particular patient for 3 months, considering costs and everything. PET CT was kind of normal in November 17 with the immunotherapy. The question is, what was the question? Many times this comes in metastatic disease when there is a very good response. Further follow-up, there was a PET in Feb 18 where a single right linguinal node, again some persistent right lower leg edema, FNAC negative. So then the question arises that is there a value of FNAC if it is negative? May 18, the lymph node has increased in size. Patient otherwise asymptomatic. And the options are surgically remove the lymph node, restart nivolumab, or like we do in penile cancer, do a formal groin node dissection. Excision of node biopsy was done. Sinus histiocytosis was the diagnosis. Again, question is again what? So patient was then kept on 6-month follow-up. Maybe he's lucky. The last was this case ends at May 22. So patient was okay till then. That's it. I think I'll stop sharing after this. So the question which Dr. Vijay will probably throw light is, he was treated in 16, 17, 18. This was made last year. So had it been 2022, would we have taken different decisions right from the beginning? This is EAU 2022, but it is almost the same flowchart. I think I'll stop sharing here. So Vijay, over to you. I mean, would we have treated differently? You already said once that I would re-challenge with the GEMSIS. Stop talking.
Yeah, actually, I would have re-challenged with the gem and platinum in this situation and then put on maintenance Avaluma, but it's okay. So what I'll do today is now, normally we talk a lot about chemotherapy and immunotherapy, but we'll talk very little about molecular therapies. So we'll go in a reverse. Even this session we'll discuss molecular therapies first. In the subsequent sessions, we will discuss about chemotherapy and immunotherapy. So just share my screen. I hope it is visible.
Yeah, it is visible.
Visible.
Yeah. So this is where we look at for second line and beyond. The first line is most of the time gemcitabine and platinum. Cisplatin would be the preferred one, or dosed and Zemvac. But in palliative settings, the interest for dosed and Zemvac is little less because of the side effects with cost. And today we would give gemcitabine and cisplatin, and after 6 cycles, we'll put the patient on avelumab maintenance. So this is what would be our first line for today in most of the patients. So there would be 2 groups here. One group would be patients who progressed when gemcitabine and cisplatin was going on. The second group will be patient who progress after avelumab or once on avelumab is going on. Ideally, avelumab goes till disease progression. So in the first section, if the patient progresses during platinum and he has not been exposed to immunotherapy, pembrolizumab has the best recommendation, and the other recommendations are for nivolumab or avelumab. Okay, so given a choice, you would want to treat this patient with pembrolizumab. The patient cannot afford pembrolizumab. You have the option of using other drugs like taxanes. If the patient has previously got checkpoint inhibitor, which means that you either treated with him avelumab, and if there's a substantial duration of time, as I told you, and if it's cisplatin eligible, and chemotherapy naive, then you would actually put the patient for gemcitabine and cisplatin. If it's cisplatin ineligible, as he has already received immunotherapy, then the choice is use a agent with chemotherapy agent with carboplatin or enfortumab vedotoxin or adrafetin. And now today I will discuss about these molecular things. Now what we must understand is whenever we say molecular, we are looking for FGFR, HER2 and all these things. Now FGFR is a fusion. Now such fusions can be detected only by either by a FISH or by doing next generation sequencing. Now in next generation sequencing, understand that fusions can be only assessed if RNA fusions and DNA fusions have been tested by the lab. So before sending the sample, always find out every NGS is not the same, whether they are doing fusions or not. And second, when you use this NGS, the fusion partners are different. So I'll show you with FGFR, there are multiple fusion partners and you need to have primers for all of them. So you need a large panel when you want to catch such kind of mutations. Now, why is this renewed interest in bladder cancer in molecular therapies? That's because you have started seeing that all bladder cancers are not the same and they are different. For example, they can be urothelial luminal, they can be basal, they can be neuroendocrine. So these all are different. And in the urothelial luminal, in the luminal papillary type is where we see FGFR3 mutations. In the luminal unstable type is where you see ERBB2, which means the HER2 new mutations. And in few types, if this is going to like a neuroendocrine variant or a basal variant, you might see P53 mutations also. Now, we must understand that these clinical features are also different. And these patients, neuroendocrine and basal, they actually do worse. You could see the median survival in the range of 1 year. While those for urothelial and luminal, the median survival is in the range of 4 years. Okay, so also understand that whenever you see FGFR3 patients been treated with FGFR3, any type of inhibitors, these are biologically good tumors. And most of the time, in comparison to these tumors which are negative, their outcomes are going to be always seem to be higher. And that is the reason why such mutations, you also need to see whether they have this such prognostic implications. Then these results for any of these inhibitors should be accepted only when they are tested in a randomized trial. If you go with respect to historical control, they always, as they also have a good prognostic indicator, they will always seem to be better. Now, this new classification, luminal papillary, you could see FGFR3 mutations, and these are fusions and amplifications. These are to be treated with FGFR3 inhibitors. Also, they also show that they have a low predictability to response to chemotherapy. Now, when you look at the luminal types, if you remember, we had looked at the luminal type here, but there was nothing. They have high expression of PDL1. So these are the tumors which are likely to respond more to immunotherapy agents. Same way, basal and squamous type, they also have a high expression of PDL1. So these are the agents which are more likely to respond to immunotherapy drugs. Now, what is the so special about FGFR3? Now, whenever there is an FGFR3 fusion, it leads to continuous activation of this intracellular tyrosine kinase domain. So what happens is, you see, these are phosphate bonds. These phosphate bonds, when released, lead to activation of PKC and MAP kinase, and which sends signal to the DNA for division. Now, normally this get activated only when the ligand gets attached to this receptor. Now, when you have these fusions activate this receptor irrespective whether the growth factor has come or not come. And how does it activate? It activates by mutations which happen in the tyrosine kinase domains. And that's the reason why every FGFR3 mutation is not dangerous. Mutations which happen in this domain, they are the only ones which are mainly dangerous. Now, these alterations are seen in 20% of the cases, and it's mainly related to FGFR3. Now, let's look at some data to understand whether FGFR3 is using this drug is beneficial or not. And this is one of the first trial of 100 patients which have progression on chemotherapy. We have seen fusions or mutations, and then we have given iridapitinib. Initially, we don't know the dose, so the doses used here are different, and then there's another different dose which has been used. And mutations which are there, which can use, are these. These are specific mutations: FGFR2 plus BICA1, FGFR2 plus CASPA7, FGFR3 plus TAC-C3, FGFR3 plus BIAP2L1. So not every mutation can be targeted. And you see, this year it has been done with PCR, and this is RNA-based PCR. So whenever you look at these fusions, you must understand that it has to be an RNA-based PCR, or NGS if you're using, it has to have RNA fusion NGS. Now, we won't go into details of this, we'll go into results. What we see is, as I told you, 40% patients respond. This is called a waterfall plot. Anything going below means the sizes decrease, anything going above means sizes increase. And what we see here is 50% of the patients have responded. Now, this is also an information which we must understand, that is called duration of response, which means they responded, but what time the duration was there. The median duration of response, if you see here, is between around 5 to 10 months. Now, does this lead to an improvement in median progression-free survival? See, it is a modest improvement of 6 months only. The median survival is only also 12 months. So that is what I was telling you, that such patient, you should not start the treatment without discussing the options of treatment with this patient. The patient must understand that in spite of these drugs being costly, the response rate is 40%, which means out of 10, only 4 patients benefit. And the overall progression-free survival and median survival at the best is modest. So this needs to be explained to the patient. And this is in spite of having the FGFR3 mutations. Now, these drugs have a typical side effects which actually lead to what is called as hyperphosphatemia and mucositis. So stomatitis, diarrhea is very common with these drugs. So these drugs are not very easy drugs to give. They cause a lot of phosphorus-related changes. And you need to do ocular examinations also in these patients, because they lead to retinal changes also. So it has got approval, but you must understand this approval is for only FGFR3 or FGFR2 genetic alterations. And this is for patients who have progressed within 12 months of the therapy. So that patient of ours, which was progressed within 9 months, was an eligible thing for this. Now, up till now, we talked about iridapitinib. That is one drug. There's another drug called ifeacritinib, and we'll have a look at this also. And more or less similar, if you could see, around 30% response rates. If you use it earlier, it leads to a better response rates with these patients. Now, when you look at FGFR3 mutation in patients who have been previously treated, you could see normally its response rate is only 25%, but you could see that progression-free survival of around 4 months, overall survival of 8 months, and duration of response only is 5 months. So these results are even poorer than intrafetal. They are not, frankly, if you ask me, are you excited to see the results? Not much, basically, because this results at the best can be said to be very modest. Now, the interesting thing is what they show here is they also tried to see whether you have a different molecular types and whether it is urinary bladder versus other part urothelial cancer. Does it difference? Actually, not much. But see, the numbers are 6 to 7 months only, and the response rates are also, it seems to be slightly higher on the other types than bladder, but understand the number of patients are very few, so you cannot actually comment much on that. There's another agent, and which is called as regorafenib, and it also doesn't have much response rate. So what I'm trying to tell you is, if your FGFR3 inhibitor is there, that doesn't mean that you use them indiscriminately. They are not like magic bullets. Intrafenib only 40% response. The duration of response in that situation is slightly better, and it has side effects with hyperphosphatemia and even ocular side effects. I have personally used these drugs in 3 patients for CNS tumors. FGFR3 is seen in CNS tumor also, and they're damn costly also. So you need to explain to the patient this risk to benefit ratio before starting these drugs. Now, people also have tried a drug called omafatamab. It's a monoclonal antibody with pembrolizumab. I would just say that the response rate will at the best modest of 32%. So really no much benefit of adding this. So what we can say in summary is, in my take, we must understand that even if we have FGFR3 mutation, we need to explain to the patient that the benefit is at the most modest. Best benefit you get with intrafetal, but that is also response rate of 40%. Median survival still is below 1 year, and progression-free survival is below 6 months, and it comes at cost of 72% toxicities. So patient has to be really motivated and explain these things before starting this drugs. Now, what if we get HER2? We saw that in one subtype, ERBB2 mutations were common. And let's look at this, like this HER2 testing is relatively simple. And this was a study in which patients got lapatinib, which is an HER2 inhibitor, which is an oral. And now it has lost patent, so it's quite cheap also. But unfortunately, you see, whether you do lapatinib or chemotherapy, the benefit is not there. It is nearly very similar. So HER2, not very promising. Now let's go at antibody drug conjugate. You would have seen this drug multiple times and a lot of talked about. So let's see whether it is actually works. Is it that good? The drug is called enfortumab vedotoxin. Now this is like a missile. So missile with a target there. Okay, understand? So actually, why I said missile, because you will see terms which are this is called MMAE payload. What is MMAE? MMAE is nothing but a microtubule disrupting agent. This is called protease cleavable linker, and this is the antibody. So this is an antibody. This antibody will go and attach its target. When it's attached its target, it will get internalized. Once it gets internalized, this protease cleavable linker will be broken by the enzymes, and this MMAE will get released. Now, it's also called cetuximab govitecan. In this, the active metabolite here, it was MMAE, which is a microtubule disrupting agent. Here it is SN38. SN30 is nothing but is a metabolite of irinotecan. Irinotecan is a drug, and it also has a hydrolyzable linker. So the same mechanism I'll show you in the next slide. So it is basically, it gets attached, it gets internalized. In the lysosomes, you'll see this linker getting broken, and this MMAE gets released, and this MMAE, it's a microtubule disruptive agent to stop the mitosis. Okay, so this causes cell cycle arrest. Now let's try to see how is there any benefit of using this drug. So this was the phase 1 study with this enfortumab, and what it showed was a 40% response rate was seen, and it actually had better promising survival of around as per around only just more than a year. Now, enfortumab after that was further used in further phase 2s in patients who were fit for platinum and also were unfit for platinum. What we see was the response rate is around 44%, and hence the interest in this drug was more. And let's try to see what is the kind of response rate if we give in patients who were platinum ineligible. It was around 52%. So this is very similar to what we saw with adrafitinib, and you could see that most of the patients used to benefit from this drug. The good thing about this drug is, like in adrafitinib, those who benefited, the benefit was for around 8 to 9 months. Here also it is for around 10 months. So more or less the similar. More or less this also has a PFS of 6 months and OS of around 1 year. So this is what we are getting with adrafitinib and enfortumab vedotoxin. For me, these are again modest outcomes, and this comes with a cost of toxicities, but here grade 3 and toxicities are really less as opposed to what was seen with adrafitinib. Now here what happens is, because this is a special type of such kind of molecules in which there is an antibody drug conjugate, they cause a lot of neuropathy, they cause hyperglycemia and skin reaction. These are common with these drugs. Now let's try to see, we didn't got this with adrafitinib, but let's try to see in a randomized study whether we saw a benefit, and this study was around 600 patients, and most of them had received previous therapies, even 20% receiving it. And it did show, as opposed to chemotherapy where the response rate was only 18%, this response rate was 40%, and there was a modest survival benefit of around 4 months in these patients. And if you see, look at this with respect to PFS also, there was a benefit. With respect to side effect also, the side effects with enfortumab vedotoxin were less. So what I'm trying to suggest to you is that enfortumab vedotoxin has got tested in a randomized study. It is a 40% response rate. The PFS is 6 months. The overall survival is just above 1 year, and its side effects are less. So if your patient is very willing and wants to do further therapy and is affording, this is a better option than chemotherapy. Unfortunately, for FGFR3 inhibitors, we don't have such data. Now let's look at cetuximab govitecan, which was trying to give a payload with the with irinotecan derivative, and you could see that this is really the same. That around 30% are responding, and PFS of 6 months, overall survival just below 1 year, with quite a few patients with grade 3 and 4 years. So enfortumab vedotoxin seem to be much better than these patients. So just to summarize, that what are the things which can do? If there is no prior chemotherapy and patient is cisplatin eligible, give the standard gemcitabine and cisplatin and followed by avelumab maintenance. If no prior chemotherapy is cisplatin eligible, then go for gemcitabine and carboplatin. If prior chemotherapy or relapse immediately, then immunotherapy can be given. There is an option of FGFR 2 or 3 alteration, then adrafitinib can be tried, but we must understand the benefit is modest. If this prior chemo and immuno both are being used, then our option is mainly enfortumab vedotoxin. But don't forget that most of the patients cannot afford this, and we need to use taxanes in this situation, and we end up using it in nearly most of our patients. And second thing, there is no harm in saying best supportive care to the patient if after your explanation the patient doesn't want to undergo any chemotherapy. With that, I'll stop, and if there are any questions, we'll take. And in the next class, I would take in depth about in the first line setting, what is the benefit of these agents.
Okay, so Vijay, just in short, can you just tell them about the neoadjuvant and adjuvant chemotherapy?
Okay, yes, I will tell you about neoadjuvant and adjuvant chemotherapy. So see, neoadjuvant chemotherapy you should be using when you are suspecting T3 or more tumor, or if you are suspecting a node positivity. Now this patient has to be fit for cisplatin, and this is the key. Using carboplatin, there is no absolutely no benefit in outcomes. So neoadjuvant chemotherapy in meta-analysis has shown to be having a DFS benefit of around 5 years of 9% and survival benefit of 5%. But this benefit comes when you use platinum agent, cisplatin, not with carboplatin. The first thing that the patient should be cisplatin fit. And there are two options which you can use. One is gemcitabine cisplatin or dose-dense MVAC. Now, if your patient is extremely fit, please use dose-dense MVAC because that has better pathological response rate and better DFS also, which is around 12% higher than gemcitabine cisplatin. So, if the patient is absolutely fit, why I'm saying fit? Because methotrexate adriamycin leads to a lot more amount of neutropenia and diarrhea. So, the patient has to have no uncontrolled comorbidity. You should preferably be young, preferably with a PS 0 to 1. All hematological and biochemical parameters should be normal. Echo should be normal. Then dose-dense MVAC should be your choice. So, in simple words, if it is, what is the indication? T3 or more or node positive. He should be cisplatin fit. If he is not cisplatin fit, please operate. He should be cisplatin fit. You should, if it is cisplatin unfit and you want to make it cisplatin fit, you should do it within 4 to 6 weeks, because if it goes beyond 6 to 8 weeks, then it is of no benefit. What should you give? Dose-dense MVAC or gemcite cisplatin. If it's absolutely fit, dose-dense MVAC. How many cycles you should give? You should give 3 cycles. This is about neoadjuvant chemotherapy. Now, what about adjuvant? Let's say that you operated a patient and now you have found that it is T3 or more, or it is node positive. Now, the tolerance to adjuvant chemotherapy is not that great. But now in this patient, there is a high risk of the disease coming back both in the locally and in the distance. So there are analyses which have shown that there is also modest benefit of giving adjuvant chemotherapy. The choice here again remains between dose-dense MVAC and gemcitabine and cisplatin. Here, at the most, maximally you can go up to 3 to 4 cycles here also, and that should be enough for the patient. But there is a new evidence which has come. That new evidence has come for nivolumab to be given as 1 year as adjuvant. In some patients, especially who are PD-L1 positive, this has shown to be of beneficial. The trial which did it also included patients with neoadjuvant therapy. So patients who had done neoadjuvant therapy, and after neoadjuvant therapy, the pathologically, even if you still see the disease is YPT3, T4 or node positive, then you can consider giving nivolumab. Patients who are there for adjuvant, and if they are not fit for platinum, then you can consider giving adjuvant nivolumab. So just to repeat, in structured wise, what is the indication for adjuvant systemic therapy? T3 or more or node positive. What would be the chemotherapy drug of choice? Dose-dense MVAC or gemcite cisplatin. If the patient is not fit for cisplatin, don't use the drug, because there is not been shown to be of benefit with using carboplatin. There is no outcome survival. How many cycles? 3 to 4 cycles are enough in this situation. Is the tolerance better than neoadjuvant? No, the tolerance is worse than neoadjuvant. If the patient is platinum unfit, then you better can try patient with nivolumab for a year, because that has shown to have some benefit. But that is also not very well accepted amongst the community, because the benefits are at the best modest. Okay. So this is in short about neoadjuvant and adjuvant systemic therapies.
So can you just tell what is a platinum unfit? I mean, patient is not fit for that. So what are the different?
Platinum unfit criteria differ according to institute to institute. There are some absolute criteria and there are some relative criteria. So platinum means cisplatin we are talking about. So I'll first talk about cisplatin unfit criteria. So cisplatin is destroyed by the kidneys and it has impact on the ears. So if the patient's creatinine clearance is below 60 ml per minute, but above 30 ml per minute, we say he is partially cisplatin unfit, which means he cannot tolerate the full dose of cisplatin of 75 milligram per meter square. But if you give weekly cisplatin, he might tolerate. But if the creatinine clearance is below 30 ml per minute, then this patient is absolutely cisplatin unfit. Next, ototoxicity. If the patient has a hearing loss which is grade 3 or more, is cisplatin unfit. Now, why is that so? That's because the patient who already has ototoxicities can also lead to, when you give cisplatin, it can lead to vestibular toxicities, and that can lead to patient having difficulty in walking around with giddiness. These two are absolute contraindications. Other contraindications are if the patient's performance status is 2 or below. So these, as Dr. Bakshi sir has shown, these are the main indications where you would say. Another indication is patient has neuropathy. So neuropathy means patient already has neuropathy, maybe because of any reason, of grade 2 or above. In such situation, if you give cisplatin, it would worsen the gain. Now understand that few of these can be improved. For example, creatine clearance, which is below 60 ml per minute, let's say it came out to be 45 ml per minute. Now, this may be because patient was taking NSAIDs for some pain, okay, or the patient was taking some drug which is nephrotoxic. In such situation, if you stop the drug and improve the hydration of the patients, it would lead to better gain. So as you can see, so in this diagram, you would see that creatine clearance less than 30 is platinum eligible, less than 50 it's platinum eligible, neuropathy is both ineligible. Now you must also understand that when you give cisplatin, now you give a lot of hydration to this patient. The hydration given is nearly 1 liter per hour. This is very fast hydration which is given. So the cardiac function of these patients has to be actually very good to tolerate such kind of hydration. If the patient has a low ejection fraction, which is below 45 to 50%, or the patient is already NYHA heart failure class 2, then it becomes very difficult. Okay, so understand that we must try to give cisplatin in adjuvant and neoadjuvant setting in most of the patients. If the patient is cisplatin unfit, but not platinum unfit, you must try to see if this can get resolved. If this can get resolved, you can actually try to give the cisplatin in weekly schedules. That also is more beneficial than giving pyruvate. Bakshi sir, you want to add something?
I don't want to add anything. Just for their understanding, I had the slides ready on another presentation, and you were talking the same. That's why I projected.
Thank you, sir.
So I think you made it quite clear, and cisplatin, about that drug also you made it quite clear. So next time what we will take? So we'll also present one good case also, and you can.
So next time we'll take, sir, we'll take this. I'll show the meta-analysis of neoadjuvant adjuvant, and also I'll talk about metastatic first line.
Renal cell भी complete करना है next time.
रीनल सेल करना है, ठीक है सर, रीनल सेल का फर्स्ट लाइन करते हैं.
मतलब अगर इतना टाइम लगता है तो दोनों तीनों कर लेते हैं, because these are more over surgery students, ना थोड़ा फास्ट जाएंगे तो भी चलेगा.
चलेगा सर. तो next time we can take RCC.
And upper tract metastatic RCC ऐसा दोनों combine करते क्या?
चलेगा सर, चलेगा.
Okay, so Ganesh, we will take case in such a way that both of you can, and with Mahendra, you can ask the questions, and then he can take over on the chemotherapy.
चलेगा सर. But moreover, case में history तो same ही रहेगी.
हाँ, history same, but some good presentation.
Here our students will need to understand basically how to finally evaluate metastatic and then how to go with first, second, third line of therapy.
Fine. Done.
Sir, can I add something? Some few lines.
Yeah.
Whenever things come towards the chemotherapy, so just like a surgical part of any therapy, you have to see the indications and contraindication, when to do, when to give, and when not to give. So those factors you must know. Everybody must know. Patient disease factor and the patient factor. For a chemotherapy decision to be given yes or no based on disease factor, but the major factor depend on the patient factors, whether the complications are more than the benefits. which is not there with the surgical part. It is very less. Okay. So as Dr. Vijay Patil enumerated the list of side effects of the individual chemotherapies, and ideally you should just have a small knowledge about those side effects so that you can avoid advising those chemotherapy to the patient. And again, where chemotherapy is not given, should go for the upfront surgery. So in exam, the examiner may ask question like this: which situation you will go with the upfront surgery? You will not give chemotherapy. So indirectly he is asking the contraindication of the chemotherapy, right? So next class you prepare and think in this way and prepare the questions in this way. Dr. Vijay, I think I am not running anywhere.
Yeah, chalega.
Okay.
Yeah.
So thank you, Vijay, very much.
Thank you, sir.
Ganesh also. At the last minute, you have given a very nice talk, and it's next time we will continue with the same.
Sir, a few questions, sir.
Yeah,
हाँ,
please,
पूछो, sir.
please go ahead.
Sir, in bladder cancer, sir, the timing of the adjuvant chemotherapy, how much can it be delayed for having actual benefit, sir?
Okay, so the question you are asking is, let's say a patient comes within 1 month after surgery, vice versa patient comes 2 months after surgery, vice versa
Yes,
3 months with 4 months, correct? So
yes, sir.
all trials now, the patients were recruited only if you could start within 6 to 8 weeks of surgery. Okay, within that phase. So we actually don't have any evidence if the patient is beyond 2 months of surgery, whether it benefits or not. We don't have that evidence beta. Okay, then it actually comes to your individual decision making, that how much nodes were present, what was the disease extent, and it's an individual decision making. We don't have evidence to guide beyond that. Okay.
Yes, sir. And sir, for GFR calculation for checking platinum eligibility, is it by the CKD EPI formulas estimated GFR, or should we go for isotope renograms?
So that's also a very good question. See, this modified Cockford and Gold formula is what most of the medical oncologists are comfortable with, and they would use it. But we must also understand this is based on assumptions. This is based on assumption that the patient has adequate muscle bulk. If the patient is very thin, especially these ladies who comes with weight of 35 and 40, in this, then Cockford and Gold many a times underestimates. So actually, before labeling the patient cisplatin ineligible on the basis of modified Cockford and Gold, it's always better that you get a DTPA scan done and get an actual measurement of the GFR done. Okay, and you would be really surprised that if the patient is very thinly built, how many times we as medical oncologists come across this situation very common in CA hypopharynx. Well, it's actually a lady who has lost a lot of weight because of hypopharynx and upper esophageal region, and you would always see that you calculate the GFR, it will the calculated GFR will always be around 40 ml, 50 ml, but when you do a DTP, it comes on 80, 90. Okay, so if there is though adequate muscle mass is not there, or if the patient has lost a lot of weight, it's better that you get a DTPA scan done. And also, in my practice, this is not in the guidelines. If it's borderline, in the sense that it is 50, 60, and you don't see any reason why she's non-diabetic, non-hypertensive, then it's better that you confirm it with the DTPA. Okay.
Yes, sir. Yes, sir. Thank you.
I think Saswat, you asked a very nice question, and we got a very nice explanation from Vijay. So next time we will not only rely on our calculations, and really if we think that patient needs chemotherapy, we should go ahead with the scan, DTPA scan, and then decide. Any other question?
No, sir.
Okay. So Ganesh, Vijay, Mahendra, can we stop here?
Okay, sir. Yes, sir. Yeah.
Yes, sir. And I think next time students may have some specific questions about the chemotherapy. Maybe who is attending the class, it is a good to clear with Dr. Vijay on that time.
Yeah. Okay.
Okay.
Okay. Sure. Thank you. Thank you very much. Good night
Thank
to all of
Thank
you.
Good night, sir. Good night.
Thank you, sir.
Thank you.